So, I believe we're ready to start the roundtable now. We are running a little bit late, and please let me know when we will finish. We have a number of cases here. I'm not sure that we have time to discuss all the cases. And the topic for this discussion is strategies for decision-making in the diagnosis of prostate cancer. We have an expert panel here. You already heard from Dr. Hans Lilja. I also put Malmo in the affiliation here, because I know you're still working there, Hans. And we had Dr. Pilar Laguna from Amsterdam, and Dr. Hernandez from Madrid, Dr. Valerio from Switzerland, the UK, if I'm correct, and myself. So, the first case we would like to discuss is patient, 61-year-old, an engineer. His clinical history, he doesn't have any symptoms, avoiding symptoms. He has hypertension, high cholesterolemia, and recently diagnosed by a GP. His PSA was then included in the testing, and they found a value of 4.1. And the DRE was normal. So, the question to the panel is then, what would be your choice there? So one choice is to perform ultrasonography directly on this man. Either you can perhaps take another PSA 4 weeks later, because we only have one PSA test, and the value was 4.1. Should we give this gentleman antibiotics and repeat the PSA test? Should we use additional markers like the 4K score test? Or is there anything else we should do with this gentleman? So, perhaps we can start from the left. Please, Hernandez, Dr. Hernandez. What is your opinion about this?
Yo contestaré lo que hacemos nosotros en nuestro centro, con un paciente similar a este. In English or in Spanish? Well, I try to answer which will be, or which would be, our studies in my team or in my center. First of all, I would like to know if there is some familiar history about prostate cancer. It's not the same if his father, brother, etc. Suffer or not prostate cancer first, but in general, I suppose not. So first is to repeat the PSA in at least 2 months before to decide which alternative to use with the patient. This would be my first choice.
Yeah, and I think you're not the only one with that opinion, I guess. I think that is certainly one way to go. Do we have any other opinion here? The next.
I mean, I will do exactly the same. I think do first simple things. So I will get an IPSS score. I'll look at whether he has symptoms. I will do a PSA density just by your digital rectal examination, and then you balance your choices. But I will definitely wait another PSA, and I will look whether he had the PSA before and he passed.
What I would like to say is that what is important and is a concept that is coming right now is this about personalized medicine. So we will ask to this patient, what do you want to know? What is important for you? Is it to know if you have a cancer who may kill you, or globally, if you want to know if you have cancer, if you want to know that you have cancer, then go for guidelines. And then we will spend our time talking if you need to be treated or not. If you want to know if you have a significant cancer, I think that at this point we have to add the 4K, and probably we have to go for an MRI in first line. So simple. And actually, this is what is happening in some centers already in the Netherlands, that the patients are going with exactly this profile, and they receive an MRI targeted plus or minus systematic biopsies.
So, but you believe that many doctors in your country, they just go ahead and may follow guidelines and do biopsy with only one PSA test? With only one PSA, which is coming from, and as in this patient, from the general practitioner. Yeah, thank you. Can we please ask Dr. Lilia if you can comment on how can we look at the risk of this patient of having prostate cancer based on all the studies you have performed here? Is there a way of thinking here?
Three thoughts. You mentioned that the individual has hypertension, hypercholesterolemia. So you would, of course, want to know what the comorbidity of the individual and if this is well controlled. Because if the individual is in good health, has no secondary damage and so on, he would likely have a long life expectancy, which I think is a key point as to whether or not to do anything more. Another point that has been raised is the repeating of the PSA test, which I think in general, when you have an abnormal lab result, you always repeat it. Though we should keep in mind that the variability of the PSA level in an individual is very small. And of course, given that he doesn't have any signs of an inflammatory condition or any suggestion of that, that would be the only meaningful way as to why the PSA would vary otherwise, or the sample had be exchanged for another sample that is not his, which is even rarer. I think thirdly, we learned that taking a biopsy on the evidence that PSA has exceeded a cut point of 3 or 4 results in overdiagnosis and a detection of low-risk disease increases significantly. So in order to mitigate that, additional risk assessment, I think, is warranted to consider. And within that scenario, of course, the marker panel that we have developed, and as a comment, we can also, because the first presentation that you made reference to the Stockholm study. So it may be worthwhile to mention that the Stockholm study actually took some reagents from our panel and put that on a different platform, never showed exactly how well the assays performed, but given that they've used most of these assays, and that they are the larger component of the effect they are seeing in their prospective trial, we must take it also as an evidence that at least there is a gross estimate that in a prospective setting you can reduce the number of biopsies used in this panel, because the genetics component and the other component that they added above and beyond these markers made very little contribution. So I think there's a lot of uncertainties about their study, but it at least shows that there is a likelihood that you would actually be able to reduce biopsies significantly using additional risk assessment with markers and so forth. And exactly where you would end up in terms of putting an additional marker panel versus an MRI, I don't think we have the data to sort that out, and we urgently need that. So everyone, I think, is thinking about that and trying to fill that gap.
Thank you. And you mentioned variation in PSA. I mean, every urologist will quite often get question from the patient if there is a small increase or decrease in PSA. The patient asks why, and so Dr. Lilja, what do we know about how much PSA can usually vary without infection being present also?
Well, a common cause of variation in PSA level is change between which test was used. That was a huge problem in the 90s when the PSA testing started. That has been mitigated, so it's much lesser, but it hasn't been eliminated because some still, for example, doesn't use the WHO calibration, which many use it, but some don't. And I mean, then it's not as bad as comparing an elephant to a banana, but it's still not ideally comparable. But given that you have the same assay performed, the variation in an individual given within a shorter period of time, like a couple of weeks, published in BJUI a couple of years ago, it suggests that the intra-individual variation is clearly below 10%, somewhere more like 5%. And if you go to a longer interval, like a yearly interval and so on, it seems to be more in the range of 10% for the majority of men. Though, as always, there is outliers. And at the moment, we have tried to identify those guys, for example, in the Göteborg screening study, where they came in 9 times in a biannual during 18 years. So we see there is outliers, and we're trying to understand what contributes to this, because it makes your life and the patient's life horrible. So that we still have something more to learn, because there is a small group of men who vary by some reason which we don't understand. But this is certainly not cancer-related, as far as we can understand at the moment.
Yeah, thank you. And that's also important to know now when we have many patients on active surveillance. What is the variation due to that has nothing to do with cancer, with the tumor? So let's move back to the case. And in this, now this patient actually had a 4K score test. And this is how it looks like. The result is 5%. So I guess we would like Dr. Lilja again to comment on this, how we can interpret this.
Well, the risk given from the biopsy cohorts clearly shows that this is low risk of a Gleason 7 or higher cancer. But I think what is more important that we, in terms of the true risk assessment of this individual, is the data from the northern Swedish Västerbotten cohort, which then suggests that for an individual with the clear PSA elevation, but a low risk score in this, would have a very low risk of metastasis years out. So the suggestion, which further needs to be filled with additional data, of course, is then that perhaps could wait 5 to 10 years for this individual with retesting, and then have another PSA and the risk score again. But the data actually suggests that this individual, who can be assured that at the moment that he is at low risk, you may want to put it back by 5 years or something like that, if you're risk prone, and if you risk avert, perhaps up to 10 years.
Thank you. Dr. Laguna, if you show this data to someone in your country that very much would like to do MRI, do you think they would like to still go for an MRI, or do you think they will hesitate if we have values information like this?
That if I show this data to some of our radiologists, and I'm talking about Netherlands, they will go, as I told you, some of them are already promoting to use MRI as a first line, as a test. But I don't think that is the discussion at this moment. I think, Dr. Lila, I don't even dare to call you my colleague because you are much higher, but has been talking about this patient with that's also true, has been talking about hypertension and hypercholesterolemia. So there are two conditions who are thus increasing and prevalent. And if you look at the World Health Organization, the prevalence in the next 10 years of hypertension at 61 and hypercholesterolemia will be almost 60, 70, or even 80%. So anyhow, though this patient is going to survive 15 or 20 years. So yes, some of them will go directly to the MRI without any biopsy, and they will be even able to say if he has high-risk cancer. Still, number needed to biopsy to have one patient diagnosis with 61 years and with this comorbidity is still worthwhile as a test, as a valid test. So still, we will not send this patient to one of our radiologists. Although it's true that now and in the frame of treatment, we are doing in those patients, we are doing all these tests, including contrast enhanced ultrasound and other techniques, and also MRI, for the simple reason, and I repeat that this is like a study, that we want to know exactly in our hands, which is the reliability and accuracy of each one of the tests.
Thank you. And I think it's the same in many places, that you would like to do everything you can with the patient. Was there a question from the audience here?
Yes,
Dr. Durante from
Thank you very much, Anders. I would like to make a comment, because the EAU Guidelines Office has been making a big effort in trying to implement its content, and I think you too have shown us very nicely that the evidence behind the 4K score is strong. It helps us a lot in trying to detect high-grade cancer. So I think there's good evidence behind. Now, there are two issues that I would like you to address regarding this test. One of them is cost. In this country, 4K score is not reimbursed by the National Health Service. It's a rather expensive test. I don't know what's the case in the US or in other European countries, so I would appreciate if you give us some information. And the other issue is also the access to the test. I understand it's done in a central laboratory. So I think that for any community or academic hospital anywhere in any European country, the access to PSA is widely available. The chance of having a regular rectal biopsy is regularly available, and that doesn't mean that you have to treat every single patient. I think we learned, urologists across the world, that we don't have to treat every single case. Tomorrow we will have a chance to discuss other options to manage prostate cancer. I would like you to address these two issues, the cost of the test and the access to the test, because I think those 2 points have limited the widespread use of the 4K score.
Thank you. Very important point. Perhaps Dr. Hernandez can comment on it.
I think that we are going to another crazy scenario. We came from a very blind place. Only we were taking decisions when PSA was more over 5 or over 4, even less. And now we are going to introduce all kinds of studies to decide if we must practice a biopsy or not. I think we must put in the middle the level, well, using the evidence, but even the common sense. Going back to this case, well, the PSA is not so high. The relationship between total PSA and free PSA is around 21%. It's not important risk. Even more, score is low, less than 7, 5 in this case. So independently that the guidelines are saying now, in my opinion, I transmit to the patient that he has a very low risk to suffer a high risk prostate cancer. So probably in this specific case, because we are talking about a specific guy, I would stop in this moment, but obviously I will go to detect the level in his PSA each year, and probably if I have introduced the 4-key score, I will test even each year at least this risk by these two alternatives. If I introduce even the MRI, I cannot analyze at this moment where I need to stop, because I need to know the PSA level, to know the 4-key score, to know the MRI, and etc., etc., etc. So we are going to a crisis scenario. In summary, in this case exactly, in this moment, I would stop, and I don't recommend to use a biopsy because he's suffering a very low risk in prostate cancer. This is my opinion, independently of that in the future, probably the next year, and I will change, even, why not? But at this moment, this is my opinion about the manage in a guy like this patient.
Thank you. Yeah, and a short comment about the costs and availability. That's of course extremely important when talking about putting new things in the guidelines. And health economy studies are of utmost important. Some years ago, we did a study in Sweden for a governmental institution to whether the PCA3 test could be recommended or not, the urine test, and it was not cost effective, so it was not recommended. It's not used in Sweden now. So that's extremely important to perform. And there is a study now from NHS on health economy and using an additional test.
So I know that there is now in the US not full reimbursement yet, but it's rolling out, so it will be full reimbursement at least by end of this year, which is based on then that it has been also been included in the NCCN guidelines. In terms of the cost, I think cost efficacy is very important here. And I think part of what we have been doing with the Psa test is to say, use it much more discriminatory, use it much more restricted, because it doesn't make sense to use it the way it was done. And their USPSTF is actually right. And I think the same applies here for the additional testing, because they should only be used at those individuals who are clearly at elevated risk and have something to benefit. And when we set up that setting, we of course need to see what's the consequence of that. Because if we are just adding burden and not adding anything that really gives important gains, then it's very questionable. And in terms of dissemination, comment about dissemination, I couldn't agree more. So the aspect about why dissemination that should be much more accessible, I agree entirely. We just do what we can from our academic setting. The commercial actors need to act on making sure that this is being more widely disseminated.
Actually, answering to our colleague, in the Netherlands is not reimbursed, and it's got to be a little bit depending as we see of what the guidelines said. What the insurance companies are doing right now in the Netherlands is, if it is not in the guidelines, it's going to be restrictive, not reimbursed, and of course that can also affect the possible the dissemination of a potentially important test in stratification.
Thank you. So finally about this case, Dr. Valerio, what would you like to do with this patient now with this information you have? What else would you like to do, or would you like to go for a biopsy now?
I think in real practice it's a bit different than here. You have a real patient in front of yourself, and you say you have a PSA which is elevated, you have a 4K test, and you get a chance of 5%. So then you go to himself and you look at its life expectancy. So you need to try to evaluate this. And I think the problem with the 4K test and the novel test is that you don't know how to follow him up in the future. So you do it today and you say, okay, you're fine. So you forget about it. But how long? So what do you do next? You can tell him you're fine, but you're not sure. I mean, we have the data. But again, it's different in a clinical situation. So I think it's a clinical discussion. I think I will tell him that the value of biopsy is very low, the value of an MRI is very low, but still I will discuss with him to look at how to follow him. I think in this case I will do a PSA after 6 months.
Okay, thank you very much. So
well, if you do, it's just a question, if you allow me, if you do a PSA in 6 months, what do you expect? A PSA of 12? Probably not. It's going to be 4.3, maybe 5, 6. So I think that in this case, we are in the same situation. It's when are you going to indicate a biopsy to repeat the risk stratification? Because 6 months, it's probably not, it's not going to change the clinical scenario a lot. It may, but then you have to suspect that there are other reasons if the PSA is 20.
Sure, I agree with you. But, well, probably our mentality is to observe how the PSA will go for the future, the tendency, more to wait very big changes about it. But if I suppose not 6 months, I think in this case, probably you can wait 1 year without any important risks for the patient. And if the PSA is going up, probably you must decide practice a biopsy. If not, if the PSA is maintained, if the patient has a very big prostate, 60 cc's, for instance, maybe I probably not to use a biopsy, at least in the first years.
Okay, thank you so much. So there are different ways to go now, and I think it's hard to know what the best way is, but perhaps many will take a new PSA test or go for MRI instead of the first two alternatives. So, one more case, if we have time for that. This is a patient, 59 years old, clinical history, He was diagnosed 10 days ago with ascites and good response to antibiotics. Prostate biopsy a year ago. Pathology showed atypia in one core, less than 10%. PSA is now at the level of 2.5. DRA is suspicious of something in the right lobe, the prostate. So here we have different alternatives. Should we repeat trust and now take the biopsies? Should we use a 4K score test, observation, or MRI, or something else? So perhaps Dr. Laguna would like to start to comment on this.
Yes, but very short. This is the patient that we will not do anything at this moment, and we will follow him in 8 weeks with a PSA. Although it was 2.5, 2.5 1 year ago, so you also don't expect a lot of things in this patient.
So avoid PSA taking right now very close to an infection, of course, yeah. So,
but in this case, to me, it's very important the digital rectal examination, because I have seen the digital rectal examination is positive or not. Positive?
It was suspicious.
Suspicious, at least. Well, I think it's a very important point to maintain. In this case, the PSA is not so important, and even more because he has suffered infection a short time ago. So, well, the PSA can change after these things. But in my experience, not only in my experience, the guidelines and etc., to have a nodule, to touch a nodule in the prostate is important. But in this case, can be that it's a consequence of a prostatitis that he has suffered a short time ago. So first, I will repeat the digital rectal examination in at least 3 months, and if he maintains this suspicious tumor or nodule, I will decide to practice a biopsy.
Do you believe you can get any support from TRUST and looking with ultrasonography at the prostate? Will that guide you in any direction?
The problem is how can we interpret the images with ultrasound? And even if this alternative is done in a very short time after an infections problem or illness. So first of all, I would like to wait at least 3 months, repeat PSA, and more important, digital rectal examination, more than the image with ultrasound.
Dr. Valeria, would you like to make an MRI, and how long would you like to wait then?
I think there are 2 key confounders in this case. So first of all, we don't know why he had an MRI the year before, because he got an infection and the PSA is still very low. So I think to answer, you need to clarify that. But let's say the PSA was 2 and was not significant. I think he is 59. If he doesn't have any comorbidities and he has a palpable disease, a clinical stage, I think he needs an MRI in order to look at whether this might be something more.
Does it make any difference to you that there was a finding of atypia a year ago?
I think it's not reliable, the TRUST biopsy. It's random. You have a palpable disease. You don't know whether it was taken or not. I think it's not reliable enough for a guy who is 59 and you want to rule out whether he has significant disease.
I'm sorry, but you need to know what kind of activity your pathologists are considering. Because depending on the laboratory, probably when there's an activity or a sample in different days, after immunohistochemistry. After immunohistochemistry, after immunohistochemistry and so on, or no? If it's no, immunohistochemistry probably has a low impact. If it's after immunohistochemistry, this atypia is dangerous because it means that in some way has racemase expression or partially residual basal cells and so on. For this reason, some pathologies like I don't use this but because it's not consensus, to use very suspicious or low suspicious. It's stupid? No, not stupid. Because in some cases you are seeing 3 glands, very malignant brackets, but only 3 glands, and it's suspicious because it's not enough to put the diagnosis. It's important the communication and to know what exactly the pathologies are trading. This is important.
Yeah, that's a very, very important point. Thank you so much. Do you often recommend the urologist to make a new biopsy because you're in doubt?
I recommend that the urologist must know perfectly what type of job is doing the pathologist. And depending on this, the recommendation can be repeat the biopsy or another marker, or no, don't worry because it's minimal and without any problem. Another additional element, if you have some atypia plus some high-grade prostatic intraepithelial neoplasm, be careful.
Thank you so much. I'm afraid we're running late. We should stop now. Okay, thank you so much.
Could I make
valid point.
I just wanted to make a note on, because I had the question about the 4K score in this setting. And I just want to emphasize, so far we don't have data to really know what happens with the score in this setting. We need to study that before we can have any opinion on how it behaves.
So we're talking about how the 4K test perform in patients with infections?
With the prior infection, yes.
Okay. Well, I would like to thank the expert panel so much for an excellent discussion and the audience for interaction, and we'll finish here. Thank you.